Thank you, David. Thank you to both the presidents of both societies and the program committee for inviting me. It was a pleasure to be at ESTI, and it's my job in these next 25 or so minutes to tell you about this entity of pleuroparenchymal fibroelastosis. A few words of background. I'm sure everyone in this room will be aware of a number of documents, the first of those published in 2002, jointly by the ATS and the ERS, in which a reclassification of the idiopathic interstitial pneumonias was presented. In 2013, there was some fine-tuning, and an update document was presented. And at the back of that document, a number of new entities were discussed, and amongst those was the entity that I'm going to talk about, pleuroparenchymal fibroelastosis. So this is the document, as I'm sure you will all be aware. And if we're just to consider the major idiopathic interstitial pneumonias, we've got the usual suspects listed here. And in this document, there was an attempt at trying to put a little bit of sort of categorization. So the IPF and NSIP were considered the chronic interstitial pneumonias. The RBILD and DIP were largely smoking related, and there were then the acute and subacute interstitial pneumonias characterized by organizing pneumonia and acute interstitial pneumonia. LIP was demoted in terms of its status as a rare idiopathic interstitial pneumonia, and there you see pleuroparenchymal fibroelastosis makes an appearance. Now, we have to credit David Lynch and colleagues in this paper by Frankel in 2004 when they first put pleuroparenchymal fibroelastosis on the map, or so it seems, when they reported 5 patients who had the clinical features of an idiopathic interstitial pneumonia. On imaging, there was pleural and parenchymal abnormality, characteristically in the upper zones, and at biopsy, features inconsistent with any of the known or recognized idiopathic interstitial pneumonias were present. And this was reported, as I said, in 2004. But it's always a sobering thought when you go back in the literature, when you go back and you actually see, probably there were other descriptions of this entity, and indeed it would appear that in 1992, Amitani and colleagues in this paper published in Japan probably were also referring to the same pathological entity. However, if you go scouring further in the literature, it's likely that other authors were also onto something. For example, in this paper in 1975, published in Thorax, you will see that the authors again talked about 5 patients who had progressive, breathlessness. There were features on lung function testing of a restrictive lung function defect. Again, abnormalities were confined to the upper lung regions. I've already mentioned it was progressive, and the authors were at pains to actually exclude tuberculosis as a possible diagnosis, because this is a characteristically upper zone abnormality. So here we are. This is taken from that paper in 1966, the chest X-ray of this one of the patients they were describing, and 6 years later, profound abnormality in the upper zones, tenting of the hemidiaphragms. This is the pathological specimen in black and white, published at that time, but you can see how there is a very characteristic abnormality in the upper zones of the lungs. This paper was titled Idiopathic Progressive Pulmonary Fibrosis, but there was, if you read into the paper itself, evidence of also pleural thickening. What I'd like to do just very quickly then is review some of the more current literature on this entity, and I've listed some papers here dating back from 2003 right down to a paper that's been most recently published in 2015 by Rosenbaum and colleagues. And I'm just going to highlight some features which will give us a flavor of the demographics and epidemiology and give us a hint about the possible causes of this radiological and pathological pattern. First thing I suppose to mention is that the number of published studies, if you look at them, the number of patients included in these studies are relatively small. There isn't really a gender predilection. The numbers of males and females in these small series tend to be relatively equal. The age range actually varies quite a lot, and this is perhaps important when I come to consider one of the differential diagnoses when we look at the radiology. However, if you look at the various papers, you can see that the ages range from age 13 in this paper by Wanda Thusen and colleagues published in 2011, right up to 87 years of age. If you look at smoking history, which is obviously something that needs to be looked at in patients who develop elements of lung fibrosis. The majority of patients in these relatively small cohorts tend to be non-smokers. Well, what about other factors which may be related to etiology? Well, there are a number of features to highlight. There probably is an autoimmune flavor, because if you look at these various series, patients with lung transplantation, patients who've undergone bone marrow transplantation seem to feature in the publications about pleuroparenchymal fibroelastosis. Now, when we think about transplant rejection, we generally think about graft versus host disease, and that generally manifests as an airways-based pattern, so obligatory bronchiolitis. So it's interesting that there is now increased recognition of something called restrictive allograft syndrome, presumably characterized by fibrosis rather than an airways-based abnormality. Another factor that comes through as a possible etiological background to PPFE is drugs. So chemotherapeutic agents have been implicated in some studies, as have some other drugs. And then there is this flavor of recurrent infections. And in this study by Reddy and colleague, published from the Brompton group, of their 12 patients with pathologically and radiologically proven PPFE, there was evidence of recurrent infection in over a half, and in some patients that amounted to Aspergillus infection. So infections, autoimmune background with lung and bone marrow transplantation, and certain drugs. These have all been implicated to date. That does leave probably a smaller cohort of patients who are truly idiopathic, so idiopathic pleuroparenchymal fibroelastosis. Okay, so we've considered some of the demographics and possible etiological factors. Now, what about sort of pathogenesis? Now, when it comes to pathogenesis, it's always nice to have an animal model of a particular disease, and it turns out that in PPFE we have a ready-made animal model, and Chris Hazlitt, who's going to be speaking after me, will be talking to you a little bit about this, because this paper actually comes from his group. This donkey is not from his group, but it turns out that pensioner donkeys have a pattern of pleural and parenchymal disease which mimics fairly closely what we're seeing in terms of imaging and pathology in PPFE in humans. These are images taken from their paper and showing this peripheral or visceral pleural thickening and the subjacent lung also being abnormal. So these are macroscopic appearances, and they've highlighted, you can see here, a little airway which is dilated, and you can see here, if you look, I know the lights are a little bit bright, but there's a dilated airway going up into that area of abnormality heading towards the pleura. And that's a feature that I hope to be able to show you when we look at human cases of PPFE on imaging. And in these pensioner donkeys, of which 32 were studied, they had evidence of visible fibrosis in 19, and these were the various features that they highlighted. So visceral pleural fibrosis, as I mentioned, the subpleural lung had evidence of fibrosis and alveolar wall elastosis. There was a very sharp demarcation between normal and abnormal areas of lung, and this was a disease that was characteristically in the upper, or when it comes to the donkey, the dorsal areas of the lung. Now, I mentioned that recurrent infections may have an etiological role, and indeed in this paper, a role for asinine herpes virus was also postulated. So it would appear that infection may have something to do with this entity, at least in donkeys. What about the pathology? What do our pathological colleagues see? Well, these are three images taken from these three publications listed here, showing the key features, this visceral pleural thickening with elastosis and the fibrosis in the subpleural lung, this very clear demarcation between abnormal and normal lung, and in this specimen, showing that sometimes the process can be very bronchocentric. So to summarize, visceral pleural fibrosis with elastic fibers, the subpleural intraalveolar fibrosis, and the elastosis in the alveolar septa. The absence, or indeed very minimal fibroblastic foci, differentiating from patterns of UIP, and this well demarcated pattern between abnormal and normal regions of lung. So now what do we see, or what should we expect to see in terms of the imaging? The chest radiograph is, of course, the first thing that we may see as radiologists, and here are two separate patients showing, again, the upper zone distribution. In this patient, pretty marked underlying parenchymal abnormality. This is a pediatric patient that was seen at King's, and I'll show you follow-up examinations in this case, but just to show how florid the pleural thickening can be and the upper zone volume loss. Now, the cynics will rightly say, well, hang on a minute. We've been seeing chest x-rays for many, many years, and we've been talking about apical pleural caps. And indeed, there are papers on the appearances of apical pleural caps. So surely this is essentially what we're looking at. Are there actually differences? Well, there probably are. If you look, and I've already shown you that in PPFE, the age range is much wider. Apical pleural caps tend to occur in older patients. In general, these patients are non-smokers. Whilst this process may be asymptomatic, the current literature would tend to suggest that this can certainly become symptomatic because it can progress. It is upper zonal, but it is not entirely restricted to the lung apices, as I'll show you in some CT cases. Pneumothoraces can occur. Apical pleural caps generally tend not to be associated with complications. And again, if we're looking at CT, pleuroparenchymal fibroelastosis tends to be circumferential, whereas apical pleural caps tend to be focal. This is an example of an apical pleural cap showing, I hope, but probably not in this light, that between 2012 and 2015, very little change in radiographic appearance. That's not the case with PPFE, and this is that pediatric case that I saw at King's, and you can see between 2012 and 2014, dramatic progression of the pleural thickening, and also there's underlying parenchymal disease, and in fact this child succumbed with respiratory failure as a result of this progressive disease. What does a CT look like? Well, two patients showing a spectrum of abnormalities. Here, in this case, there is relatively minimal pleural thickening with some subpleural abnormality, much more dramatic in this patient on the right-hand side, clearly showing the pleural thickening and the upper zone predilection for this pathological process. Another thing that you will notice when you look at the axial images is this squashing effect, so-called platithorax, that occurs in patients. And here, both, if I'd given you all the sections, you would appreciate that there is reduction in the AP diameter of the hemithorax, which is a feature that we will see. This is progressive disease on CT. So this is a patient in 2006, and 8 years later, in addition to developing these bilateral pneumothoraces, which is a complication, as I've already mentioned, you can see the pleural thickening, the associated subpleural parenchymal abnormality, and note also that the airways are dilated. Remember that case from Chris Hazlitt's paper showing the airway dilated in the periphery of the lung, and I think that is a feature which points towards this diagnosis of PPFE when combined with the other features that I've just highlighted. Shown in even more dramatic fashion here, look at the airway dilatation associated with this pleural and subpleural abnormality, and in addition, these focal areas of what look like consolidated lung. Now, PPFE in some patients, as shown in this study published from the Brompton, will be associated with features in areas remote from the areas of obvious abnormality in the upper zone. So in this cohort of 12 patients, Reddy and colleagues saw that in just under half there was an appearance consistent with an interstitial lung disease in other zones of the lungs. So in 3 patients, there were features somewhere in between NSIP and UIP. A single patient showed features of NSIP, and in another patient, it was an unclassifiable, but nonetheless appeared to be an interstitial lung disease. Interestingly, in 2 out of those 12 patients, there was also a family history of fibrotic interstitial lung disease, so possibly pointing towards a genetic predisposition to lung fibrosis as characterized by PPFE. So in summary, what should we as radiologists be looking for in PPFE? Well, pleuroparenchymal thickening is a cardinal sign, tends to be bilateral, and as I've already highlighted, in the upper zones. This is associated with subpleural abnormality, with reticulation. of variable severity, as I've also shown in some of the CT examples. Remember the flattening of the AP diameter. The airway dilatation, I think, is a useful sign, particularly if you've got serial examinations and you can see those airways dilating up in conjunction with the abnormalities in the pleura and the immediate subpleural lung. Some patients will have abnormalities remote from the areas of obvious PPFE, typically in the mid and in the lower zones, and also you may see foci of consolidation in the subpleural lung. So if you're looking at PPFE, are there any diagnostic criteria that you can use? Well, again, I turned to the paper by Reddy and colleagues, and they attempted to say, well, there are signs that will allow you to make a definite diagnosis in CT, because not all of these patients will be able to undergo biopsy. So if you have pleural thickening with subpleural fibrosis in the upper zones, and there is nothing else elsewhere, or it's relatively limited in the mid and lower zones, then you are able to make a definitive diagnosis of PPFE based on radiological criteria. If, on the other hand, you have those features, but it's not concentrated in the upper zones, or you have coexistent disease elsewhere based on the accepted criteria for interstitial lung disease as set down by the various respiratory societies, you can call it consistent with PPFE. And of course, if you have none of the above, then the features you're looking at are probably unlikely to be those of PPFE. So in summary, ladies and gentlemen, PPFE might be a newly recognized, or maybe more accurately acknowledged entity, but it probably was around for many years, but it appears now in the updated classification of the idiopathic interstitial pneumonias. It's probably rare in terms of an idiopathic entity, and it probably represents a pleuroparenchymal response to some insult. Now, whether that's recurrent infections, whether that's some element of autoimmunity, possibly on a background of bone or lung marrow transplantation, or whether it's due to drugs, or whether it's due to some combination of all of these, we don't know, and I'm sure time will tell. However, it is recognized. It's recognized by pathologists, and I think increasingly now by us as radiologists, and I thank you very much for your attention.